So this is the case presentation we'll shortly be showing. We can discuss a little bit before we go in live.
Is the slide going to change?
So male patients, I think stable angina, right?
Yeah, sure.
And 54, hypertension, smoker. Next slide.
Is it the same patient that's working there?
Yeah. So here, most importantly, I think EGFR is 50. You have to be concerning how much contrast you're going to use in this procedure.
Fair LV function.
Yeah. And ECG shows the dynamic T wave changes, I guess, probably in the inferior leads, infralateral leads, that are T wave inversions. Maybe a right coronary, we don't know. They're not very consistent with the lesions in the coronary arteries. Next slide. So there you go, as the ECG is not consistent here. It's still angiogram of a left coronary artery, showing a severe coronary artery disease in the left main, and also possibly in the left anterior descending artery.
Can you go back to this ECG? No.
Go back to the ECG, please. Previous slide. Previous. Okay. No. Previous slide.
The ECG slide.
The ECG seems to show inferior wall infarction.
No AVR ST.
Okay.
Okay,
Next,
please. Just take care.
Oh, we can do that.
Okay.
Nothing in the AVR.
Nothing. Yeah.
Yeah, there's nothing in the AVR. Okay, yeah.
So again, the lesson is never feel too confident about the diagnosis from ECG alone.
Yeah.
So far as the territory is concerned.
Right. And I agree with the Q waves in the inferior lead suggesting a old inferior wall MI.
Yeah, possibly posterior as well because the R wave is tall in V1.
Right, yeah. R wave in V2 is larger than S wave.
Yeah, there
Here's a still angiogram of a right coronary, right? I think there is a discrete 95-99% lesion in the mid RCA, and also proximal to this that there is another 60-70% lesion. Ostium, we are not very clear whether there is osteal lesion or not, but there is reflux coming into the aorta. So that is it. So now we can discuss.
Good morning.
He's not tolerating this, so I need to hurry up.
Fajila, can you listen?
Yes, ma'am, আপনার সাথে কথা বলতেছি।
Yes, please. Yes, I can listen.
Hello?
Can you
Hello,
hear us?
hi.
Can you hear us?
Yes, we can hear you.
Yeah.
Yes, we can.
Yeah, Fajila, I am Dr. Ranjan Datta from Kolkata. Welcome.
Hello, how are you doing?
Yeah, welcome to this session.
Thank you.
I have with me Dr. Ramesh Dagu from USA, Dr. Dagubati from USA, Ramesh, Dr. Mahanan from Kerala, Dr. D.P. Sinha from Kolkata, and Dr. Anil Mishra from BM Birla, Kolkata. We are all eagerly looking forward to your procedures. If you have anything to make comment on, you can do that right now.
কেসটা ওরা প্রেজেন্ট করে ফেলছে কিন্তু ওরা।
Right, so you've already seen the case, and one thing that I think needs to be emphasized here is that this gentleman has pretty severe disease, right? His right side is involved, a coronary which is fairly large, and if you look at the left side, the lesion in the left main is fairly complex. There's a dissection as well in the left main, and the left main is pretty severely diseased. Another challenge is that the LAD has a very steep angle as it arises from the left main, and the L6 is also very angulated. And wiring these two vessels is going to be a challenge, as we found out. So a fairly young gentleman, his creatinine somewhat raised, DFR, as you've already pointed out, somewhat compromised. He's got severe triple vessel disease, including left main disease, and the left main shows a dissection with pretty severe disease and severely angulated origins of LAD and LCX.
Was he offered the option of bypass surgery?
Yes.
Yes, of course, there was an option of bypass
Creatinine
surgery,
issue.
but here we did discuss with the heart team, and it was the patient's choice, considering that he's reasonably young. He leads a fairly active life.
Creatinine
He
issue.
works in the Middle East and he wants to go back to his job. And as we've already pointed out, his serum creatinine is raised as well. And if we had sent this patient to surgery, and if the patient would have wanted surgery, this case would not have been discussed here. So obviously, after a prolonged discussion with our surgical colleagues, it was decided that he will undergo PCI. Surgery was definitely an option, but considering his creatinine and the rather active life, which he felt would be compromised by surgery, it was decided that this would be a PCI.
What will be the syntax score in this case?
Actually, I'm sorry that we did not measure the syntax score here, but I
28
would
around.
presume that it would be pretty much high, and it would not be one of those low-risk PCIs. So it would be, I mean, I'm assuming, but someone, I think we should have counted it, but we did not.
I like the answer, but Fazila, this is Hiremat, that we didn't count the syntax score
Hi,
right, the lesion
Hiremat,
for
how are you? So
angioplasty.
you root for me there, okay?
So there is something called eyeball testing. I think if we try to get away from PCI, we'll count it.
Shirish, what do you think his syntax score would be? I would assume something like 28 or 30 or something like that.
Monan, since you
my
asked the question,
assumption.
why don't you answer? What's your guess? Syntax score?
It'll be definitely less than 32. That's
30.
Less than 33.
Yeah, it will be less than 32. Yeah, but something around, that's what I was saying, something like 28 or 30, something like that.
I think this is time to modify syntax
And,
score now,
Nobel
isn't
did
it?
that.
Yeah, because I think we're
Yeah.
able to achieve so much so easily, so I guess the older generation is now going to change. But I guess we need to wait for that.
And even in the United States, we don't regularly do syntax score.
I think you can give us your strategy of approaching the problem. What do you want
Okay, so the thing is, we've done a bit of work here because we've just got half an hour of transmission, and this was a fairly complex case. So what we did is we initially tackled the right side, you know, and you can see the right side, a fairly large vessel, and here we wired the vessel, did pre-dilatation. Can you show the pictures, please? So the pictures are running, and you can see wired the vessel with a run through, did pre-dilatation, and after that we went on, proceeded to use two Resolute, Endeavor Resolute stents in this RCA. 3.538 and another 415. So that was what we did. Okay, so this is the, and this was the 415. The RC after stenting. After this, we went on to the left side, and as I was pointing out,
Fazila, I like this
Let's have a
idea
look
of
at the
doing
left
right
side. Also,
coronary
this is the RCA.
first because I think it stabilizes the patient a great deal. It's a simple lesion, so better fix it and then proceed to the left. So that even during the procedure on the left, if you get ischemic occasionally, the right is already stabilized very well. So I think this is something which we should normally do. In fact, most of the time when we talk of left main bifurcations, we are presuming right is normal, and then we argue how to approach the left main. So it's a good idea to fix the right.
Yeah, there was a concept earlier
Thank
that
you.
fixing the difficult one first, because in case we fail to do that unnecessarily, the one stent will get wasted. But if you have confidence enough, you can probably go for the right one first.
If you all remember, earlier days we used to say a right coronary obstruction was a contraindication to left main. So now it's changed naturally.
Yeah.
But again, you'd always want to fix the right first to make sure that you're safer when you do the left main. So that's an important lesson to learn there.
Absolutely. And after that, we've we've just started the left, which we are planning to do live as we intend to. So you can have a look at the left coronary artery, and you will all agree that this is a fairly complex lesion. As I was saying, the left main looks dissected angiographically, and pretty severe lesion, LAD angulated, LCX angulated and diseased. So wiring was not that easy. We've just wired, as we were going live actually, we just wired the vessels. Just 5 minutes prior to that, we could hear the constrictive pericarditis lecture as we were wiring. And wiring the LAD was a bit of a challenge, but wiring the LCX proved to be more challenging than that because of the severe steep angle. So we first went into the rammers, and then we couldn't really wire the LCX. But eventually, just as you said hello, our wire decided to go in, which we greeted with a sigh of relief. Okay, so that's what we've already done. We've wired the LAD and the LCX, and there's an extra wire in the rammers that went there, which we didn't really require, but since it was there, we've kept it there. And after that, we just now did an IVUS run. Okay, and if you want to have a look at our IVUS run, we've got both IVUS in our cath lab, the Boston as well as the Volcano, but we're more sort of used to and comfortable with the Volcano, and we've used the latest catheter, which has a very short tip. It's very it's got a very low profile, and it's called what?
IVUS short tip.
Okay, it's called IVUS short tip catheter, and someone can show this photo to the. Can you focus on the camera on this, please? On the. Yes, so that's our Volcano newest catheter, very user friendly, and I mean it's got such a low profile. It really doesn't make that much of a difference if you're doing a left main, but if someone's doing a CTO and really wants to find the true lobe, because it's only 2.5 millimeters. So you can imagine how near you can go to the CTO and have a real good idea of what's happening. So we'll show you the IVUS pictures, and now we're going to focus on the IVUS pictures, and you can see the LAD has fairly very diffuse disease, and there's some calcium, and there's pretty heavy disease burden in the left main as well as the proximal LAD. And actually I was just making the comment that our patient did not even tolerate that IVUS catheter as well, and that's when you people joined us. We've just done the IVUS run, and you're having a look at that.
Dr. Fazla, what's your choice of guiding catheter?
It's an No, what's a catheter? It's an 3.5 EBU. It's a 3.5 EBU. Initially, we took one without side holes, but then, the pressures were looking a bit ventricularized and all. So we went to for a 3.5 EBU with side holes.
Just a question to my fellow panelists.
Now we're going to do our pre-dilatation.
What was your strategy before the IVUS? Was it changed? Has it changed after your imaging?
What did you, excuse me, I didn't get your question, please.
What was your strategy to begin with?
Strategy changes even.
Dr. Mohan wants to know, has
I thought we
IVUS
would be
added to
discussing
your...
and go for the strategy. Yeah, well, IVUS has added to my idea of what the strategy should be. I would need to see the LCX, you know. This time the IVUS has not made significant difference in my strategy, but it has reinforced what I knew, and that is that there is a significant disease both in the LAD and the LCX.
I guess.
So what is your strategy, Fazila? Because we know that both the arteries are diseased and
strategies first.
left main has significant disease burden with some calcium. So what's your strategy now?
Yes. My strategy would be to first initially predilate. After predilating, my strategy is to stent from the left main to the LAD, then recross into the LCX, which will be a challenge, and have a look how the LCX behaves, and maybe put a second stent in the LCX if required. That is the strategy at present. But if I can get away without stenting the LCX, that nothing like it, because that would be such a help. Because as Ku has already pointed out, hasn't he? Even if there's apparent angiographic lesion in a side branch, but if you do an FFR, you'd find that the lesion is not that significant physiologically. So let's see how things go, and we'll go from there. So basically now we've done predilatation, and after predilatation, the plan is to put in our stents from the left main to the LAD, and then decide on what we need to do for the LCX. So that's after our predilatation.
So I guess the proximal LAD is also going to get a stent. So you put the distal stent first and then the proximal stent in the left main. That's the strategy.
I think that would be good, right? So we'll put the stent in the LAD first and then go for the left main to LAD.
This is especially because the patient is fairly stable as we see, so we have enough time to address the left main. So quickly put a left LAD stent and then a left main. Actually, putting two stents under these kind of setting gives you a lot of flexibility to stretch the back stent to the fullest. So maybe we take a 4.0 at the back and stretch it to 4.5 or even 5.0 based on your IVUS observation.
I mean, I think I would encourage people to use IVUS and left mains mainly to size it. If they are going to be not sizing according to the Finesse law, if you can do that, that's good. There can never be a left main which is 2.5 millimeters. If somebody is going to deploy a 2.5 millimeter stent and explain to me that because he's an Indian, I don't believe it. You have to just actually do an IVUS to show that truly it is a 2.5 millimeter left main. I think that's where
actually,
I think
we've really increased our use of IVUS, and this has sort of made us use more of larger size stents. Nowadays, we usually go for 4, 4.5, even 5 is also very commonly used in left main. Because once we started doing IVUS a lot in left main, it completely changed our sizing of the stent. So now we're taking a
IVUS LAD 3 দেখাচ্ছে.
In IVUS, the LAD shows it to be a 3 millimeter vessel. So we are taking a 3/30 for the 3/38 for the LAD.
And what about left main?
The left one comes as 4 millimeter in the IVUS.
I believe in Dhaka you have 4.5 stents too. We don't have it here.
Yes, we do. We've got 5 as well. I mean, it's such a blessing to have, onyx with, some people have huge left mains, and it really does help.
Caudal view নিতেন? Inflate, ma'am.
So we're inflating our stent in the LAD, a 3/38 stent, and we've gone up to 12 atmosphere. That's it. Take it out.
EIICCON ওয়্যারটা
Mine of the peripheral ones.
There are people who do regular IVUS, even in Indian arteries, they feel the LAD every time can be stretched to 4, every time. So I think we have to change our concept based on IVUS, and I would imagine IVUS helps you to expand the stent to the fullest, sort of pushes you to use a bigger sized non-compliant balloon for post-dilatation.
Caudal view
There is, of course, wrong side too, you sometimes may overdo stretching of the diameter.
This is particularly true for a left main and LAD.
Very true.
Very often the problem comes when you put in a 4 mm stent in the proximal LAD. The distal lens is total mismatch with the rest of the lumen.
proximal LAD পর্যন্ত লেফট মেইন স্টেন্ট
How do you deal with that? Distal edge of the stent
Now
becomes
we're
a total
taking our
mismatch
second
with
stent.
the residual lumen of the rest of the artery.
No, distal is 3.0 and it is stretched to say around 3.3. So I think putting 4.0 at the back or 4.5 also should be okay.
Yeah. We can have stents like the newer varieties, the Onyx and others, but you can, distal, proximal one, you can probably increase much more than what the existing ones are now.
Yeah, so
4.
But Onyx is not available now here.
4 নিয়ে নেন।
We
lot
had
of
a
things are
query
happening.
to the panelists. We have a stent. Our IVUS is showing that the left main is 4 millimeter, and the LED is like
Proximal LED,
proximal LED is like 3.25, something like that. So do you want us to take a 4 stent from the left main and go to the LED
Sure.
and sort of do minimal dilatation in the proximal LED, and then do, or we can take a 3.5 and do a higher pressure in the proximal left main. But I think I'll take a 4. I'll take a 4, go to the minimum with an Onyx, and then I'll do post dilatation in the left main.
ওর অনিক্সটা দেখাইতে পারে।
Actually, while choosing the
So we're
length of
using
the
an Onyx. Okay, so the length is 4 by. Can someone have a look at? Can you show us this? So that's our Onyx, a 4 by 34 Onyx. We're using a 4 by 34 Onyx from the left main into the proximal LAD. And we plan to go to the most nominal like 8 or 10, and then we'll do pre-dilatation for the post-dilatation for the left main.
Actually,
Yeah.
while choosing the length of the proximal stent, one must also keep enough length for doing a pot, because I think the smallest length of
Absolutely.
4.5 balloon available in India is 8 millimeter. So preferably, it's good idea to keep a slightly extra length at the back so that you can do an adequate pot, which actually facilitates your passage of wire to the circumflex very easily.
Philip, push.
So pot is always on my mind when I'm choosing the length for the left main bifurcation.
Yeah, I think Hiramod, that's very important, that proximal optimization helps in crossing the side branch.
আয়োটাই দিয়ে দেন।
So that pins you little
So
needs.
now, you know, since we're going to cover the ostia of the left main, easy technique to, you know, identify the ostia is to put a cuspal wire, which we just did now. We took the ramus wire and we took the ramus wire and put it in the aortic cusp. Now that gives us a fair idea of where our ostia of the left main will be, right?
Yes, and as I see, the angle is also elaeocranial, right? I think angle also becomes very important to get the osseum.
Yeah, I would go more cranial.
Absolutely.
Just make sure that LAO for 30 and cranial 40 will
Infiltration
give
is
us
not-
actually the origin of the left main.
6, 8, 10।
I mean, this is a
That's
technique that some
Ajay,
people
Ajay,
use
Ajay,
it. I
Ajay,
have
Ajay.
Name it
not
down,
been
name it
using
down.
it regularly, putting a wire in the conus, in the
Conus,
aortic
and-
sinus.
Yeah.
Sinus.
I think keeping a few millimeter proximal to the proximal end of the left main is more practical rather than trying to get exactly the same size.
You know, my anxiety when you do that, Anjan, you know, once you have something hanging into the aorta, taking a stent to the circumflex becomes quite a challenge.
Yeah, that's and just few millimeters so that you can, by doing pot you do away with those extra length.
If you already fix the circumflex, I don't mind coming back and floating into the aorta a little bit. But I think if you put your stent at the ostium, taking another stent sometimes can be a big challenge,
that also
especially
gives-
a longer stent.
That also gives you a test whether it has been rightly put or not.
Oh. You would sweat too if you can't get into circumflex.
Here I think the presence of the dissection is prompting her to do it up to the ostium possibly.
In any case, Fazila, you must agree that the basic principle or philosophy of stenting a proximal LAD and left main is to see to it that you don't use undersized stent. Obviously, because you should have,
Absolutely.
it has a great potential of, if you look at the
That's
proper assessment with IVAS, is very important in getting the right size, and you should not feel shy of using
Absolutely.
the higher size and post-deployment, proper
Absolutely.
post-deployment as well.
I think all long-term
So now
results
we
are...
have a jailed, we have a jailed wire in the LCX, and we plan to recross into the LCX, which is maybe a bit of a challenge. So let's see, fingers crossed, how things go.
Why not do a
So
pot
we've
before we
deployed a
try and...
stent from the, yeah, we've already done pot actually. I think you people were discussing, so you missed it, but with the same stent balloon, we pulled it and we went to higher pressure. So our struts are hopefully well opposed, and we'll try to wire the LCX now.
Again, going back to a question I said earlier, would you have chosen a different guiding catheter for this left main?
I think sounds good to me. I mean, I would definitely take this as a first choice. There were 3 wires, so if you're going to use side branch stenting by more percentage, maybe I would have taken 8, but I think 7 EBU is my choice too.
So I do most of my procedures radial. I still, even for left main, I actually go with the 6 French EBU 3.5. Even for DK crush can be done with 6 French guiding catheter. So I don't really go for 7 French unless really if that is, if I'm deciding to do simultaneous kissing stents, which is almost never nowadays. So my choice of 2 stenting is double crush, double kissing crush technique, or a single technique is, as shown here, provisional is 80% of our practice anyway. So I think EBU 3.5 is that your question? EBU versus some other JL?
Yeah, you see the EBU tends to suck in every time you try to manipulate things inside, and that may distort your proximal part of the left main stent. So that is always a little concern.
I would 100% agree with you when it is an ostial
Left main, yeah.
If it is ostial left main, I also take JL, because you can go in and out very easily over a wire with JL. But this is too many things to do inside the left main and LAD, so I think EB would offer a better support in this case.
Actually, putting the sinus wire there would have helped. Sinus wire there, which she withdrew.
It all depends on the
already
angle.
there are 3 wires, so...
No, sinus wire.
Yeah, the wire to define the ostium, the radiopacity, I think it has some advantage, but maybe you can do without it.
Yeah.
Because since you are going for the radial approach, you probably use EBU even in left main proximal or ostial left main. Otherwise, it's right that having an EBU with ostial left main is fraught with problems of getting stuck and probably injuring the proximal end of the left main. So you feel more comfortable with the other ones.
Yeah, actually the right word is what you're comfortable with.
Yeah.
Every guiding catheter can be sucked in too deep sometimes. So you have to make sure that it is not getting sucked in, and use the catheter that you're comfortable with.
So we see, Fazila, you're crossed into circumflex and you pulled out the trapped wire, is that correct?
No, before I pull out the trapped wire, a common practice that I do is I take a small balloon and see whether the balloon goes easily or not. If the balloon goes easily, it means that I am in the proper position. If the balloon does not go, I do not do any pushing. I know that maybe I'm under the struts, so I take another wire and just recross again. So this is a common practice, a very small thing that I have been doing over the years, and it has served me well. So let's see, so now is my acid test. I'm taking a 1.25 balloon, and if it should go, it means that I am well and it means goes easily, so it means that this wire is in the proper position, and now I can take out my jailed wire. My jailed wire, I'm taking it out now, and there it is. And when I have too many wires around, I also tend to put a jailed wire, so just to know which wire to pull, right? Because once you're in the excitement of doing a left main live, you just in the excitement might pull the wrong wire, and you don't want to do that. So, small things like this do add up and help. So we are opening up the strut, and after this we plan to have a look again with our iris.
I didn't see, was there even disease at the ostium of the circumflex to start off with?
Yes, there was disease in the ostium of the circumflex, and that was the concern. There was. So you want to have a look at the ostium again? We can show you a previous picture, or we can take a picture right now, and you can have a look.
Fazila, I would like to see the initial picture and picture after deployment of the LED stent.
Okay, so the initial picture, yes. I'll show you the initial picture.
And after deployment of LED stent, or left main for that matter.
Yes, sure.
Fazila.
So let's hurry up.
Fazila, do the way you want. There are a lot of examiners here.
Yeah, I know.
We're asking you a lot of questions.
Okay, so let's have a look.
Back.
This won't show, so let's go to the...
So we are trying to see if after stenting it could have been left alone.
Yes.
That's what you're trying to
So
say.
my question is that, are we done? I know there is a distal circumflex lesion, but...
Yeah, sure. There you go. Can you see the picture?
Yeah, I think there is disease.
Yeah, there is disease, no doubt.
No question on that, yeah. All right, let's see after stent how we are.
So that was, if it were disease-free, it would have made my life a lot easier. For sure. So now let's have a look of up till now what we've done. So we have put a stent in the LED. We've put a stent in the left main to LED. We have, fingers crossed, been able to rewire the LCX. And now we want to have open up our strut, and let's see how it looks.
Yeah, Fazila, most of the time we must compare ourselves with the surgeons when you're doing this kind of complex case. And just as surgeon would revascularize as much as possible, even now we try to revascularize as much as possible. So what's the thought at the moment? Are you going to stent the circumflex?
What do you think?
What do you think?
I would stent it, yes.
I mean, it's a fairly large territory, and I think we should do him justice by putting a stent there and then do a final kiss.
I think this is a very good scene at the moment for a T with protrusion kind of stent to the circumflex. It would be very easy to do that. And the angle is also very good for doing it.
Yeah, it's good for the tap, I think.
Yeah. So, I mean, I probably would not do the stenting here because I'm not going to treat the distal circumflex lesion. If I'm going to treat the distal circumflex lesion, then I'll treat the proximal one. Otherwise, I think I'm done. In my opinion, this patient has already benefited a great deal from RCA, left main, LAD, PCI.
Suggest a fractional flow reserve at this point for the circumflex. That also a reasonable option. If it is negative with intravenous adenosine, we can.
No, but there is a distal disease in that circumflex.
No, the one where there is no disease, then we can one of the branches which doesn't have a disease.
Post procedure IVUS also will definitely help.
Now the important question is that what is the definition of optimal result? Are we happy what Ramesh told? That there is TIMI3 flow and the lesion looks to be around 50% in the proximal LCX, and there is a difference in opinion among the authorities that what is the optimal result. Because there is good flow, no doubt about it, what Ramesh told. But again, there is some disease, 50-60% lesion in the ostium of the circumflex.
So, I mean, we have seen over time that when we try to make the pictures look beautiful, those are the patients who would come back with recurrent myocardial infarctions.
Yeah.
But where we left these left main or side branch lesions like these and they give aggressive medical therapy, they had not come back. So we have gone around
Because now the medical therapy is also versatile. You know, we have got good antiplatelets, DAP for some time. So and things are quite different in comparison to what it was 10 years back.
I do agree with Ramesh because in order to put a stent there, I don't know finally whether the picture would become the same or better or even worse. All the three options are there.
Just they stop short with the dilatation of the LCX
So what do you suggest? The ostium of the LAD, LCX looks pretty decent. Do you want us to stop here, have a look with the IVUS and do another report in the left main and call it a day? Or do you want us to put another stent? I mean, this is a live case and we are open to suggestions. Our patient is stable, hemodynamically, he is pain-free. The LCX, we've opened up the strut and done a bit of pre-dilatation there. It doesn't look that bad. So do you want us to just do a report and call it a day, or do you want...
Yeah, Dr. Fajil, I think I agree with Dr. Hirema. There are so many examiners, you should do what you're comfortable with. But that said, I think a report is number one. Go ahead with the report. But we will come back to you to see the final images. We'll just quickly go to the next room and come back? Or are you the same person who's going to be doing the next case as well?
The next case we are going to do. So our time is up now.
So,
yeah, Fazila, you carry on with the procedure. We'll see and come back to see the final result in half an hour's time.
Next patient.
The opinion is that you have all the three options. You can leave it there, you can reassess, and you can do reporting, and then finally probably the call is in your hand.
Report korbo.
Yeah, so we're doing report now, and after that we'll do our IVUS and decide from there, and we'll show you it during our next case. Okay?
Okay, fine.
Thank you.
Thank you very much.
Thank you and well done.
Thank you for being such wonderful examiners, and thank you.
Thank you to Dr. Fazila Nisa Malik and her team, and esteemed chairpersons and expert panelists. Thank you very much.